This patient case took place in the University Medical Center of Hamburg-Eppendorf in Germany. The University Medical Center Hamburg-Eppendorf is the largest among Hamburg's hospitals with approximately 1,400 hospital beds. The range of medical care extends from overall diagnostic service to highly specialized and complex treatments for uncommon diseases. An obese male with a history of heavy nicotine abuse was admitted to the hospital 4 days ago. Since then, he has been expectorating yellow mucus. Increasing dyspnea was evident. Physical examination revealed bilaterally reduced air entry and a prolonged expiratory time. After reviewing his lab analysis and X-ray of the thorax, which showed on the right lung basal infiltration, the diagnosis was hypoxic and pulmonary insufficiency due to an acute infective exacerbation of COPD. The patient is going to be taken to the ICU to be monitored and ventilated non-invasively with PC BiPAP. After the disposable Dräger Classic Star mask was adjusted to fit comfortably on the patient, PC BiPAP ventilation was started using an FiO2 of 50%. The inspiratory pressure was then slowly increased from 10 millibars until the necessary tidal volume was reached. The patient is now ready to be transported to the ICU. With Carina, you have the possibility to go on intra-hospital transport using the cylinder holders on the Carina. 2 oxygen cylinders can be easily transported with the patient, and the internal battery provides up to 1 hour of operation. The tidal volume fluctuates between 30 and 115 milliliters, which is much too low. The doctor suspects that due to the reduced consciousness, the upper airways are obstructed. She decides to ventilate this patient for a short period of time via a nasopharyngeal tube. After only a short period with the nasopharyngeal tube, the tidal volume increased to achieve a more consistent minute volume. The patient's blood gases improve, and as a result the FiO2 can be reduced to 30%. The patient is becoming more active, and the doctor decides to use the mode Spontaneous Pressure Support, or SPON-PS. This spontaneous breathing mode provides a pressure-supported flow-cycled breath when the patient triggers a breath. Due to the growing tachypnea of the patient, 5 milligrams of morphine is prescribed intravenously. After another 60 minutes, the patient's consciousness improves significantly. He is awake and calm. The ventilation therapy is continued via mask application. Over the next several hours, the patient is ventilated using a mixture of oxygen therapy and non-invasive therapy. In order to wean the patient, the breaks between the next NIV treatments are increased. The patient feels better and can now sit up in his bed. When he drinks, the nurse removes the mask and Carina automatically lowers the delivered flow. Additionally, for a set time T disconnect, no alarms will be audible. This feature increases the comfort of your staff and of the patient when the mask is being taken off. When the patient has finished drinking, he can put on his mask again. Carina automatically restarts ventilation with the former settings. His condition improved significantly, and after 30 hours, ventilation was discontinued. This patient case took place in Hamburg, Germany. Please be sure to follow your hospital's guidelines on how to treat your patients and how to proceed with ventilation.